Good afternoon. How many of you are seeing this flower very carefully? Can you see the water droplets on them and the number of the droplets? Why I am saying this is that as radiologists we must develop our brain muscles to pick up in a short span what is relevant. Today we would be talking on relevance of sonohysterography. We will not be discussing sonosalpingography because sonohysterography itself is a big treasure in itself. I always tell my students that we are not just radiologists but clinical radiologists, and so I would like to bring some cases in front of you where sonohysterography, why it is important. So just imagine a lady who has walked into your clinic who with a complaint of postmenopausal bleeding is hypertensive and taking tamoxifen for CA breast, and she is referred for pelvic sonography. You do a sonography and you find that she has a thickened endometrium. Similarly, one more case if we take, there is a lady with post menses spotting, 49-year-old post menses spotting, and she has already undergone pelvic sonographies at various places and her report was normal, and now she is referred to you for second opinion. So what do we do? I would definitely want to do sonohysterography in both these cases because sonohysterography enhances the endometrial lining to and shows the clear lining so that we can differentiate between the various problems which were missed on regular transvaginal sonography. Many more conditions can be appreciated, and ideally sonohysterography should be done to determine the cause of this abnormal vaginal bleeding, whether it was pre or postmenopausal. Sonohysterography clinically utility lies in the ability to distinguish anovulatory bleeding from an anatomical lesion. In postmenopausal bleeding, it can help distinguish between atrophic and anatomical lesions. So, besides abnormal uterine bleeding, it is of importance in evaluating cases of infertility where there are repeated abortions, in evaluation of submucosal myoma, endometrial polyps, intrauterine adhesions, uterine synecdoche, and also in seeing congenital abnormality of uterine cavity. And also when you have done a previous TVS, standard TVS, and you find that there is some abnormality, or clinically the patient had symptoms but you are finding a normal TVS. So, but prior to sonohysterography, I would always consider and ensure that lady is not pregnant and she is not having PID, so, and not having excessive vaginal bleeding. Baseline sonography is must before we do sonohysterography because we know our starting point. I always insist on transvaginal sonography. I feel any lady coming to your place for sonography, you must do a transvaginal sonography. If not done, I say it's a crime. So when should we do this sonohysterography? Between day 5 and day 10 of menstrual cycle, if that lady is having regular menses, that is before ovulation, so that we do not disturb her pregnancy if at all it has occurred. If the lady has irregular menses, then it should be a pre-procedure UPT should be done. In a postmenopausal lady, it can be done at any time, and patients on hormone therapy, it should be done at the end of progesterone phase. Why we cannot do before day 5? Because the blood may obscure the pathology. So sonohysterography as I mentioned, we should always do a baseline TVS. Color Doppler can be done, and then we go to sonohysterography. We should explain the procedure to the patient, take a written consent, take brief gynec history. If the patient is anxious, she may be given muscle relaxants or painkillers, and prophylactic antibiotics is actually not needed in every cases, but if she has PID, yes, it can be given. The position preferred is lithotomy. We here generally prefer pediatric catheter of 5 to 7 French size. It is inserted through the os and up to from the cervical canal into the internal os. The balloon is placed above the internal os. I will not be telling the details of the steps because, but I would definitely want to highlight where attention should be paid. One is that the balloon should never be inflated when it is in the cervical canal, because or just at the internal os, because it is very painful. To avoid this pain, the bulb should be inflated when it has crossed the internal os. Around 1 to 2 ml of saline is put in the balloon, and then we insert the TVS probe. The amount of fluid instilled should be just enough to visualize the pathology, and it depends on the patient's tolerance. So just to around 5 to 10 ml is more than enough to see the endometrial cavity. But yes, if you are doing a sonosalpingography, you need to inject lots and lots of fluid, and it can be anything between 40 to 200 ml. All portions of endometrium should be imaged carefully, because we may have some focal lesions or diffuse lesions. The aim of doing sonohysterography is twofold. One, to know whether the endometrial lining is normal or not, and if at all it is abnormal, whether it is focal or localized, diffused. So here, once we have injected the fluid, we can see that this fluid is sufficient to outline the endometrial lining, and we are seeing different types of endometrial lining. It can be smooth, there can be endometrial fold, there can be a polypoidal growth, or it may be irregular. It is important to know whether the lesion is focal or diffused, because accordingly further management is planned. If it is a focal lesion, we can do hysteroscopy and take biopsy from that area. But if it is diffused, we can do directly DNC and take biopsy from any part of the lesion. So it helps the referring gynecologist to plan. Intracavitary polyps can be easily identified once the fluid is inside. What is important for us to diagnose is the number of polyps, whether it is pedunculated, and whether there are more than one, and the location, so that the gynecologist can plan accordingly. If the point of attachment is the stalk is thick, then hysteroscopy is advocated. If it is thin, then we can go for polypectomy, maybe on an OPD basis also. So how do we take this measurement? We take at the neck level and at the broadest part, and then we take the ratio, whether it is less than 1 or more than 1. Accordingly, we define whether it is sessile or pedunculated. So hysteroscopic removal is the decision which has to be taken by the gynecologist. Now, for fibroids, The submucous fibroid impinges on the endometrial cavity and distorts the endometrial cavity, and that is one of the important causes of menorrhagia. So, how big is this protrusion inside the cavity is important, because then accordingly we grade the myoma. Grade 0, where more than 100% of the myoma is protruding inside the cavity. Grade 1, where more than 50% is protruding in the cavity. Grade 2, when less than 50% it is protruding inside the cavity. Now what if it is grade 0? That means it is 100% protruding. You need to do a hysteroscopic resection. And if it is more than 50%, that also needs a hysteroscopic resection. If it is less than 50%, we can do a myomectomy, open or laparoscopic. So, sonohysterography can help estimate the percentage circumference projecting into the endometrial cavity, grading it as one of the most important part of our report. It is a must. Now coming back to the case we were talking about when we started with our lecture, a lady coming with post-menses spotting. So this lady came to us, and when we could, here we could just see a protrusion, irregularity in the endometrial lining, and 1 minute. So as the fluid is there, we can see more than one protrusions inside the endometrial cavity. So when we have just done a plain sonography, we feel there is only one submucosal fibroid, but when we actually have fluid inside the cavity, we can appreciate that there is one anterior one also, one posterior one also. So you can see how it delineates and makes our diagnosis more confident. Here again, that patient of tamoxifen, we got to see endometrial hyperplasia. Tamoxifen is known to cause anti-estrogenic effect on breast, but not on the uterus. The endometrial lining, we can have thickened endometrial lining. On doing biopsy, this turned out to be a non-malignant hyperplasia. Adenomyosis, we just saw a case of adenomyosis. Dr. Jitendra Sahu demonstrated it very nicely. But just see, when we inject fluid, how nicely we can pick up at the endomyometrial interface the cystic lesion, which otherwise in 2D we would have thought it is cystic hyperplasia rather than an adenomyosis cyst. Uterine adhesions may be cause of impaired fertility, and the endometrial lining may appear normal at conventional TVS, but the moment we inject fluid, we can appreciate the synecdoche. Patients with history of pregnancy loss and instrumentations have adhesions. It's a common finding, and so with sonohysterography, as fluid instilled into the endometrial cavity, bridging bands of tissue that distort the cavity can be identified. Thick adhesions may make it difficult to distend the cavity, and it may be painful. So we should be very careful while injecting the amount of fluid. Hysteroscopy can be performed for the lysis. This is one condition where we must do sonohysterography prior to lysis and then post lysis also. So sonohysterography, which provides enhanced endometrial visualization during standard TVS, is relatively a safe procedure and does not have ionizing radiation effect. Sonohistography is typically used in patients for whom standard TEVS does not show the endometrium well. So there is better characterization of pathology. And I must say in conclusion that TVS sonography is must in every pelvic cases, and when we want to see the endometrial lining better, we should do a sonohistography. Thank you so much. All these ladies from 19 to 91 are really thanking sonohistography for the benefits it has. Thank you.
Thank you, dear participants, for your patient hearing and listening. And also, we are thankful to you for airing your queries regarding the topics, and we would like to answer your queries to the best of our ability. Now, one by one, we will go through the questions which are being asked. Question 1 is, should we include subendometrial hypoechoic halo in the endometrial thickness measurement? As I told you in the first talk, the subendometrial halo is not to be included in the while measuring the endometrial thickness. Only the endometrial echogenic lining or the endometrial myometrial interface, echogenic interface, has to be included in the endometrial thickness, and also the thickness of anterior as well as the posterior wall combined has to be included as a total complete thickness. So one wall thickness is incomplete, so include both thickness of the both walls, anterior as well as posterior wall. So I think that will address your query. How to diagnose ootestes from ovaries in case of absent uterus? This is a very rare disorder. Uterine agenesis is a very rare disorder, occurring in almost 1 in 50,000 around cases. And ootestes means a presence of ovaries as well as testes. And this patient has ambiguous genitalia. And to diagnose ootestes, we knew because the size is so small that it is very difficult to assess them on transabdominal ultrasonography. So we need to do MRI in such cases, and if needed, we should go for a biopsy to differentiate the ovary as well as testes in these cases. Question number 3 is, if follicle reduces marginally in size but has hemorrhage in it, has it ovulated or is a hemorrhagic cyst an ovulatory? Since the size of the follicle has reduced marginally, which suggests that it has ruptured and ovulation has occurred. Sometimes after rupture of the dominant follicle, it becomes a corpus luteum. Sometimes in the corpus luteum, you may see a hemorrhage, and in the form of internal echoes. So we suppose that this is a corpus luteum which has undergone a hemorrhage. So the cycle may not be anovulatory. So we consider this as a corpus luteum with hemorrhagic corpus luteum. Question number, next question is calcification in postmenopausal ovaries abnormal? And we need a follow-up. Do we need a follow-up? Dystrophic calcification in postmenopausal ovaries is considered normal unless there is increase in the size of the ovary beyond the permissible limit, that is more than 8 cc volume in postmenopausal woman is considered abnormal. So if the ovarian volume is less than 8 cc, Even if there is a calcification, it is considered as a normal finding. Next question is how to search for ovaries on abdominal USG which are devoid of dominant follicles in case of a child of less than 10 years in suspected case of ambiguity or a Turner syndrome who has not yet undergone any genetic testing, especially when ovaries are small and follicles being confused to bowel artifacts. Now in a 10-year-old child, it is very difficult to locate the testes, locate the ovaries on transabdominal sonography. So naturally the MRI would be the modality of choice in this case, and MRI can help in diagnosing these cases. MRI, T2 weighted MRI pelvis is the best modality to, it also demonstrates the follicles also. So even if the follicle size is small, it can demonstrate follicle up to 1 millimeter. So MRI would be a better choice in this case. On MRI, will there, next question is, yes. Okay. Another question is, a case of 22-year-old unmarried phenotypically female but couldn't find her uterus well on USG. Only ovaries were seen, which are small in size. What to interpret? So if you are doing a transabdominal sonography, so what you see should be interpreted. So if you see the ovaries, interpret them as depending on their appearance, and if uterus is not visualized, you can mention that the uterus is not appreciated, and further evaluation in the form of MRI is a better choice. Next question is 39-year-old married female with 2 kids presented with bleeding PV and pelvic pain. She was diagnosed of early menopause 5 years back. Now a 39-year-old married female with 2 kids, bleeding PV. So since the 39 years of age, the patient has attained menopause quite early, and post-menopausal we have to look for, if she is presenting with a bleeding PV, we have to find out the cause for bleeding PV, post-menopausal bleeding PV, and applying all the criteria of normality of ovary as well as testes, ovary as well as uterus, we have to subject the patient for further evaluation, which can make the diagnosis correctly. Next question is when to call it hypoplastic uterus. So there are normal dimensions of uterus depending on the different ages of the patient. So for to anything to be called hypoplastic, it applies to uterus also. So whatever criteria for hypoplastic organ is applied to uterus also. Normally there are percentile methods. So different agencies use different books has mentioned a percentile method. So you have to find your own convenient method to call it hypoplastic, because literature has given a different criteria for anything to be called hypoplastic. So I think this is one part of the one part is over regarding the queries. Now I would request Onkar sir and Dr. Sahu sir and Kadam madam to take over the next queries.
So one question was for ovulation studies, referring doctor asked to do if only per abdomen ultrasound in our center. Is per abdominal follicular monitoring apt way to report, or should we deny to ask for TVS always? So as I said in my presentation, follicular monitoring is always by TVS, and not any transabdominal examination is obsolete now. So always recommend and ask this referring doctor to go for TVS only. Then another question is, in ovulation study of dominant follicle doesn't rupture by day 20, then for how long should we continue the study to look for rupture and if follicular cyst is formed, and when to reassess and how to measure the endometrial volume. So basically, if a dominant follicle is not rupturing after day 20, so it is becoming a retention cyst or unluteinized cyst. So basically, in these cases, we have to leave this study and we have to ask this patient to come in another cycle. And for taking the endometrial volume, so few machines are having endometrial volume assessments by 3D. So in Voluson, there is a vocal, endometrial volume estimation by name of vocal. So every machine is having a different setting and to calculate the endometrial volume. So high-end machines are having this endometrial volume assessment, so you can take use of it.
There was one more question. Is TVS warranted in every asymptomatic postmenopausal female in whom endometrial thickness and ovaries are not well seen on per abdominal? Is her referring doctor request needed to convert a transabdominal sonography to TVS? To convert a transabdominal sonography to TVS, it is the patient's consent which is needed, and the consent of referring doctor is not required. It is the patient's consent which is important. If patient doesn't give consent, you can't do it, and the doctor has nothing to do with in such cases.
The question was whether we need to do TVS in every postmenopausal women. Yes, I would say the answer is yes. Today, no female pelvic examination is complete without a TAS and TVS.
There is a question: how can we suspect presence of deep pelvic endometriosis in a patient on transabdominal ultrasound and go ahead with TVS? Or any case with dysmenorrhea and dyspareunia or dysuria should be evaluated with TVS? As madam and sir, everybody has said, it is always advisable to do a TVS in a pelvic ultrasound in addition to transabdominal. You may do a transabdominal ultrasound followed by TVS, but that is a must now as per all these guidelines and current protocols. So I think most of the questions we have done with.
There was one question. In unmarried female, if diagnosis is not certain on transabdominal scan, what next to offer? MRI pelvis or transrectal scan, considering the cost factor? So since we are doing a transabdominal scan which is inconclusive, in my opinion, MRI pelvis would be the better choice, though the cost factor is of some concern, but MRI pelvis would be the best choice in such cases. Transrectal again has its limitations, and hence in such cases MRI pelvis should be done.
Yeah, I think MRI is an excellent modality to evaluate pelvis and its various pathologies. But ultrasound definitely is a great screening plus evaluating tool, and in most of the cases when we can conclude definitively on ultrasound, need not go for MRI. But in inconclusive cases or where there are mixed features, definitely we should take help of MRI, and that should not be forgotten. I think with this we come to the end of today's live web workshop from the Department of Radiodiagnosis, NKP SIMS Nagpur. I will again thank all my fellow faculty members, the administration, the Samsung Electronics, WatchWiz Technologies, and most importantly our students who always work hard behind the screen to get the cases, recording them and presenting them before you. So again, thank you all, and we may meet in near future with some newer programs or some newer ideas. Thank you.